Okay, everybody. Thank you for your patience as we waited just a few minutes for everybody to get on. So we're going to get started. My name is Sarah DeFeo, and I'm the Director of Scientific Affairs here at the Ovarian Cancer Research Fund. And I want to thank you all for joining us today as we continue our webinar series for 2015. So tonight we'll be learning everything you need to know about ovarian cancer risk. OCRF's webinar series has been supported by Genentech, and I want to thank them for their generosity in making this possible. So to start, just a little background information about OCRF. We are the largest and oldest charity in the U.S. funding ovarian cancer research. Our mission is to fund scientific research that leads to more effective identification, treatment, and ultimately a cure for ovarian cancer. Since we made our first grant in 1998, we've awarded over $65 million in research grants. Now, before we get started, I have just a few housekeeping notes to go through. All listeners will be in a listen-only mode throughout the presentation. We should have some time for questions after the presentation, so if you think of a question as you're listening, you can type it into the Q&A box that you should be able to see on the right-hand side of your screen. Now, no one else will be able to see the questions you ask, and you won't be able to see anybody else's questions, but I will see them all, and I'll select some to ask to Dr. Burchuk at the end of the presentation. So there's no need to wait until the presentation is over. You can just submit your questions as we go along. I do ask that you try to keep your questions as general as possible so that the answers will be useful to everybody who is listening. So I'm very pleased to have Dr. Andrew Burchuk with us tonight as our speaker. Dr. Burchuk is a GY oncologist at Duke. He's been at Duke for over 20 years, and he's currently the director of Duke University's Division of Gynecologic Oncology. And he also serves as director of the Gynecologic Cancer Program at the Duke Cancer Institute. He was educated and trained at Case Western Reserve University, University of Texas Southwestern, and Memorial Sloan Kettering Cancer Center. Dr. Burchuk is involved in caring for women with gynecologic cancers on a daily basis while also leading a nationally recognized program in translational research at Duke. He's involved in a number of national activities, and he served as president of the Society of Gynecologic Oncology in 2007, and in the past he's also chaired OCRF's Scientific Advisory Committee, which he did for many years, so he's a great friend and supporter of this organization. So, Dr. Burchuk, I am now going to make you the presenter, and
Good.
You can start. I can hear you, so you're ready to go.
Fantastic. It's an honor to be able to do one of these sessions. The Ovarian Cancer Research Fund is the largest charity awarding research grants in the field of ovarian cancer in the United States and in the world, so it's really been a labor of love for me to know you, Sarah, and Audra Moran, and all the other OCRF staff, and to work closely with you. For the next 30 or 40 minutes, I'm going to talk about ovarian cancer risk, what you should know, what you can do. Hope everybody can hear me okay.
We can hear you. Don't forget to share the file.
Oh, do I have to share?
Yes.
Hold on, sorry. So I'm going to the screen here, and I'm going to hit
share file or share your desktop.
Let's see, where is that?
There's the quick start tab.
Quick start, okay.
Then in the middle it should say share file.
Got it. Okay, so now I'm going to switch back to the presentation.
All right, now we can see it. Thank you.
Now. Good.
Oops. Thanks.
Okay, so I'm a bit of a rookie with these webinars.
Doing great.
So I'd like to start off this talk by just painting the big picture. Ovarian cancer is a disease that's very near and dear to many of our hearts, very personal for me because of the hundreds, probably thousands of women I've taken care of over the last 25 years, but probably many of you who are on this phone call have a personal interest, either because of your own experience with the disease or perhaps family members. So big picture is that the good news is that ovarian cancer is not among the top 3 causes of cancer deaths in women in the United States. But the bad news is that really nothing much has changed with the mortality rate from ovarian cancer over the past several decades. I think often one can get fatalistic and feel like cancer's always been with us, it always will be with us, and we can try to treat it better, but it's never going to go away. But when you look at here about a 75-year perspective, you can see that in the 1930s, stomach and uterine cancer were the two most common causes of cancer deaths in American women, and these have gone down by 80 or 90%. Stomach cancer because of better refrigeration and less nitrates in foods. Uterine cancer because that includes cervical cancer, and screening for cervical cancers had a huge impact in detecting dysplastic changes in the cervix before they ever turn to cancer. So we really can see positive changes. The flip side of the coin, the bright red line, lung cancer, wasn't even in the top 5 causes of cancer deaths for women in the earlier part of the 20th century, but as women gained equal rights, they gained the equal right to smoke and get lung cancer. Fortunately, we're starting to see the crest of that wave. Finally, we're reducing incidence of smoking in this country from about 45% to under 20% now, and so we're just starting to see a dip in deaths from lung cancer. In the past 20 years or so, breast cancer and colorectal cancer death rates have started to fall as well. Breast cancer, maybe because of screening and early detection and better treatment. Likewise, colon cancer, better screening with colonoscopy, perhaps somewhat better treatment. Really, pancreatic and ovarian cancer are the two cancers that have remained in the same sort of position in terms of mortality rate and haven't seen much changes. They're both cancers that arise deep inside the body, for which we don't really have good screening tests, and unfortunately, by the time you have symptoms of pancreatic or ovarian cancer, it's often more of an advanced stage disease that can't be surgically treated while they're still confined to the organ. So ovarian cancer is what we're here to talk about tonight, and I put ovarian cancer in quotation marks because we're now learning that most of what we've thought of as ovarian cancer actually probably starts in the fallopian tubes, about 2/3 of cases. But at this point, ovarian cancer is the 5th most common cause of cancer deaths in women, but again, relatively rare compared to colon, lung, and breast cancer, at least in the U.S. Most of these cancers start in the fallopian tube and spread from there and present at an advanced stage with disease around the abdominal cavity. Although early stage cases are highly curable, most of these are not the high-grade fallopian tube type, but are rather endometrioid, clear cell, or mucinous type cases that are less aggressive and more likely to be diagnosed in an early stage, regardless of whether they're picked up on just a routine pelvic exam or because of symptoms. So this is the reason that we do cure some ovarian cancers. In the last few decades, ovarian cancer has primarily been treated by gynecologic oncologists who have specialized training in surgery and chemotherapy. But even though the subspecialty of gynecologic oncology has evolved, and I think we're really the best at treating this disease, the overall cure rate of about 40% hasn't changed much, if at all. It really just fractionally by a few percentage points, if you believe some of the data that's out there. Unfortunately, we still have no approved screening tests for the disease and are not really in a mode like colon or breast cancer where we talk about screening and early detection, at least not yet. So this is just a real-life picture looking through a scope in the belly button, a laparoscopy, and it's focusing in on the right diaphragm. So the liver is at the bottom of the frame, and then there's a rim of fluid in the middle, and then you can see these tiny little nodules on top of the diaphragm or underneath the surface of the diaphragm. And so this is really the problem with ovarian cancer, is that from the fallopian tube, it has free access to spread around the abdominal cavity. And often at the time of diagnosis, when we go in and do surgery, there are hundreds, if not thousands, of little implants. And try as we might to remove all of the cancer, it's almost inevitable that at least microscopic cancer will be left. So if we'd like to detect ovarian cancer early, there's a number of obstacles that we have to confront, some realities. First of all, as I mentioned, the ovaries and tubes like the pancreas are deep inside the abdominal cavity, not easily accessible like a cervix is, where you can stick a speculum in the vagina and swab the cervix and do a pap smear, or wind a scope through the colon, or palpate the breasts. The ovaries and tubes are deep inside the abdomen. In addition, the precancerous lesion is not really easy to detect or identify in the fallopian tubes. Again, in the cervix, we can detect this with a pap smear, and even with a scope looking at it with colposcopy. With the pre-invasive lesions in the fallopian tube and in the ovary, they're very small and, again, not very accessible for looking at them and biopsying them and trying to find it before it turns to cancer, to fully invasive cancer. And then also the problem with ovarian cancer is it's not rare, but it's relatively rare compared to some of the other more common types of cancer. So the rarer a cancer is, the harder it is to screen for it in general, because any screening test will inevitably have false positive results. So the more rare a cancer is, or any other disease, the more likely a screening test is to have a false positive and to result in other workup or evaluation or even surgery to try to make sure that you don't have cancer. And so the false positives and the implications of evaluating a lot of people who don't have cancer are considerable. And if you read the newspapers, there's been a lot of similar sort of talk about using PSA for screening for prostate cancer. You find a lot of things, but don't necessarily prevent deaths from prostate cancer. As I've already mentioned, early cancers don't produce a whole lot of symptoms generally. If you try to evaluate women who have symptoms, they typically already have spread of the cancer outside the tubes and ovaries. And then I also alluded to earlier the fact that cancers that are detected at an early stage tend to be the other histologic types, the endometrioid, the mucinous, the clear cell, that are less aggressive and less likely to kill somebody in the first place. So again, screening has to be about preventing ovarian cancer deaths, not just detecting cancers. So let's talk a little bit more in detail about ovarian cancer symptoms. As I've mentioned, they tend to be nonspecific: abdominal distension, dyspepsia, pressure, urinary frequency. Most of the time women have those symptoms, it's not ovarian cancer. So you can't do surgery on someone just because they have those sorts of symptoms to see if they have ovarian cancer. That said, I think too often general medical doctors, family practitioners, and others don't even think about ovarian cancer when those symptoms are present. So certainly in the presence of those symptoms, getting a pelvic ultrasound to look at the tubes and ovaries and a CA-125 blood test is appropriate in the evaluation of those symptoms to rule out ovarian cancer. So that's different than using an ultrasound or CA-125 as a screening test in the general population. It's evaluation of symptoms. It's a medical workup. But that said, a number of large studies have been done at Duke and at other institutions showing that earlier workup or recognition of symptoms doesn't eventually translate into improvements in survival. So in the early 2000s, there was quite a bit of emphasis, New York Times articles, et cetera, really focusing on how people should be more aware of ovarian cancer symptoms. But unfortunately, that hasn't really been translated into reducing death rate from ovarian cancer. So let's focus a little bit on the CA-125 blood test. So CA-125 is a substance that's produced by ovarian cancer cells, and when a woman's diagnosed with stage 3 or 4 ovarian cancer, about 85% of the time, the CA-125 blood test is elevated. One problem, though, is it's not often elevated in stage 1 cancer, so the majority of early stage cancers, where you can go in and take the cancer out and the patient's cured, don't have an elevation in CA-125. That said, the CA-125 test is used very frequently. Women who have ovarian cancer get the CA-125 test almost every time they come to see the doctor, because the CA-125 tends to be elevated when you're diagnosed, and then if you have surgery and treatment, it comes back down to normal. And then if there's a recurrence of the cancer, it goes back up. So it's actually more sensitive than any kind of pelvic exam or physical exam or even CAT scan in monitoring the course of ovarian cancer over time. So that's been very useful. In addition, many women with ovarian cancer present with a pelvic mass, but most pelvic masses are not ovarian cancer, they're benign. So the CA-125 blood test has also been somewhat useful in distinguishing between a pelvic mass that's probably benign or probably cancer, and this can be helpful in deciding whether a general OB-GYN does surgery or whether that patient's referred to a gynecologic oncologist for surgery. Now, it's certainly not a perfect test, but along with other information, can really be helpful in making that decision about who does surgery. As far as screening, early on, it was appreciated that about 3% of healthy postmenopausal women have a CA-125 level that's elevated for one reason or another. And so when 3% of the population over age 50 has an elevated CA-125, it's a real problem, again, in terms of false positives. So fibroids, endometriosis, pelvic infection, a number of other different sorts of issues can elevate the CA-125 much more frequently than CA-125 is elevated because of ovarian cancer. Here's a little more about pelvic ultrasound. On the left is an ultrasound of an ovary that has cancer, so you can see some of those solid areas. The black is empty space or fluid, so a benign cyst would be mostly black and empty space. Here on the left, where those three arrows are sort of forming a triangle, you can see there's some tissue there that's a solid growth of tumor that's a malignant ovarian cancer. On the right side, you can see that where it says F, those are follicle cysts, so you can see functional cysts. And so an ultrasound can see a cyst or a mass or an enlargement of the ovary, but again, most of the time, that's not going to be ovarian cancer, and most of those women don't need surgery. So about 25 years ago, the National Cancer Institute started a large prospective screening study with looking at evaluation of screening tests for prostate, lung, colon, and ovarian cancer. So this was called the PLCO study. And for the ovarian part of the study, about 78,000 postmenopausal women were randomized to either be screened with CA-125 and ultrasound yearly or not to have the screening. So in the screened patients, the CA-125 was done annually for 6 years in a row, the ultrasound for 4 years, and then the patients were followed during that time and for 12 years in total. Again, half of these 78,000 women didn't have the screening. And so here's the randomization, 39,000 to screening, 39,000 not screening. In the usual care arm, there were 176 ovarian cancer diagnosed, 77% of which were advanced stage. In the arm that had the annual CA-125 and ultrasound, 212 ovarian cancers were diagnosed, 78% were stage 3 and 4. At the end of the day, there were 100 deaths from ovarian cancer in the usual care arm and 118 deaths actually in the ovarian cancer screening arm. So there were more ovarian cancer deaths by number, but the difference is not really statistically significant. So the conclusion is that there was really no difference from the screening in terms of ovarian cancer deaths. So the mortality rate index ratio is 1.18, but the 95% confidence intervals cross 1, so it's basically what we call a null or negative study. However, in the arm that was screened, again, 39,000 women, there were 3,285 surgeries because of a false positive screen with either elevated CA-125 or ultrasound or both. And of those 3,200 women, 166, or about 5%, had at least one serious complication from this surgery. So the conclusion of this study, which was published in 2011, is that screening did not reduce the mortality from ovarian cancer in these 79,000 women, but it did cause harm because of unnecessary surgeries and complications from those surgeries. So I think this study that was published in 2011, after more than 2 decades of a prospective study, really put a damper on screening for ovarian cancer. But all hope is not completely lost, because a group in England, in the United Kingdom, has also been doing a study for over 20 years that's looked at using CA-125 and ultrasound in somewhat of a different way. So again, the problem that I mentioned with screening with CA-125 is that about 3% of women over 50 will have an elevated level. So this slide shows over time the serial CA-125 levels in women who are being screened, and for three of the curves that sort of go in a straight line and have green little circles like this one here are women who turned out not to have ovarian cancer. So you can see these are years, 1989, 1990, 91, 92, 93, 94. So this patient here was followed over years, and the CA-125 was elevated. It was over 50. It was probably 100 or more. No change really over time, just like this one and this one. Whereas the patients who developed ovarian cancer, the levels increased over time. And so basically the screening study that they're doing in the United Kingdom doesn't just use a single CA-125 cutoff for normal versus abnormal, but it uses something called the ROCA, or Risk of Ovarian Cancer Algorithm, where if you present with a sky-high CA-125, that would be considered a positive test. But most of these CA-125 elevations are more lower level, and then you repeat the CA-125 every 4 to 6 weeks, and you determine the trend over time, and you also do an ultrasound, and then if the trend is rising, like in this patient or in this patient, then those patients go to surgery. And with that approach, at least in the initial report from this study, they could do only about 8 or 10 operations for every case of ovarian cancer, so a much better chance of finding ovarian cancer and a much lower case of operating on women needlessly when they don't have ovarian cancer. So actually, on December 17th, 2015, in less than a month, the results from the UK screening trial are going to be announced. And this is probably the largest prospective clinical trial that's ever been done in oncology in women, and maybe for any disease in the world. I don't know. But there were over 200,000 women that were randomized in this trial to this multimodal approach that I just described with the ROCA CA-125 algorithm, transvaginal ultrasound by itself, and then a control group who haven't been screened. So there have been 100,000 women who've not had screening, 50,000 that have had the ROCA screening with the serial CA-125s and ultrasound, and then a group with ultrasound alone, with then abnormal screens being referred to GYN oncologists. So I'm very excited. Ian Jacobs and Usha Menon, who've been the principal investigators of this study, are good friends and colleagues of all of us. And so on December 17th, we'll find out whether any of these approaches was able to reduce the death rate or at least increase the average survival of women diagnosed with ovarian cancer. So stay tuned for that. I'm sure many of the high-profile media, New York Times and others, will be reporting on the results of that study. So the other area that's important to talk about in trying to avoid ovarian cancer is genetic risk. And in 1994 and 95, 2 genes were discovered, BRCA1 and 2, that we know majorly increase the risk of ovarian cancer. So on the left side is the lifetime risk for breast and ovarian cancer in women who carry a BRCA1 mutation. So you can see the risk of breast cancer starts to increase around age 30 or even a little sooner. And by the time women reach age 70, there's about a 60 to 70% risk that a woman will get breast cancer. For ovarian cancer, the risk starts to rise at a little older age, around age 40, but by age 70 also gets to around 40 or 50%. Different studies show different numbers, and you can see these are the confidence intervals here, so these estimates are not precise. Fortunately, the risk of ovarian cancer doesn't start to rise with BRCA1 until about age 40, and most women have had their children at that point and finished their family. So for the last 20 years or so, we've had the ability to test women for BRCA1 and BRCA2 mutations and start to do prophylactic surgery before they get ovarian cancer. Here on the right side, you can see the lifetime risks for breast and ovarian cancer with BRCA2. So for BRCA2, about 50–60% lifetime risk of breast cancer, and then about a 10 or 15% risk of ovarian cancer. You know, the population risk in the United States is only about 1–1.5%. So these are dramatically higher risks of ovarian cancer. And about 1 in 400 women in the general population carries one of these mutations. For BRCA2, as data has accumulated over the years, it's become clear that the risk of ovarian cancer doesn't even start to rise till about age 50, or maybe even a little higher. So I think for BRCA1 carriers, we're anxious to start removing the tubes and ovaries before or around age 40. For BRCA2, if women are done having their family, also around age 40, but certainly if women desire fertility or just don't want to have the surgery quite as soon, we're more comfortable going to around age 50, but again, with the lack of a good screening test, not entirely comfortable. So historically, testing for BRCA1 and 2 mutations has been done based on personal and family history of breast and ovarian cancer. You know, if women have both breast and ovarian cancer or double breast cancer, or cancer at an earlier age, you know, the average age for ovarian cancer is, again, about 60. So if women are having ovarian cancer in their 30s or 40s or breast cancer in their 20s, then that's also a tip-off. BRCA2 increases the risk of breast cancer in men, so that's also a clue. Ovarian cancer being relatively rare raises our eyebrows pretty much at any age, particularly if there's also breast cancer in the family. And then Ashkenazi Jewish heritage. Most American Jews are Ashkenazi, originating from Eastern Europe, and whereas the general U.S. population, I said before, about 1 in 400 carries a mutation in BRCA1 or 2. In the Ashkenazi Jewish population, it's 1 in 40. So the chance of carrying a BRCA1 or 2 mutation is 10 times higher in Ashkenazi Jews than in other individuals of European or African origin. More recently, we've actually started to do genetic testing on all women with ovarian cancer as this has become less expensive. And as I alluded to earlier, now that we can test for these mutations, women who are done with having children can have their fallopian tubes and ovaries removed, and this is really the best prevention for ovarian cancer. It's about 90% protective against ovarian fallopian tube and what we call primary peritoneal cancer. You know, most of these cancers probably do start in the fallopian tubes, but fallopian tube cells can flake off of the ends of the fallopian tubes and plant on the ovary or on the peritoneal lining in the pelvis. And so removing the fallopian tubes is the main thing. By removing the fallopian tubes and ovaries, you prevent about 80% to 90%. There's still some of these cancers that can arise in the peritoneal cavity. So it's not 100% protective, but again, about 80 or 90% protective. Fortunately, we can now do the surgery laparoscopically or robotically, and tiny incisions, good cosmetic results, don't even need to stay overnight in the hospital. If women who have the prophylactic surgery don't already have breast cancer, then they can also receive estrogen replacement therapy. And some would say that the main benefit of the prophylactic surgery is the reduced risk of breast cancer because, again, breast cancer is even more common than ovarian cancer in BRCA1 and 2 mutation carriers. So if you remove the ovaries with the fallopian tubes, you'll reduce breast cancer risk dramatically, and this may save even more lives than the prophylactic removal of the tubes and ovaries. So everything's always in evolution, of course, and so now that we've understood that most of the cancers are originating from the fallopian tube, some have started to say, well, why not take a 35-year-old woman and just remove her fallopian tubes and let her keep her ovaries so she doesn't go through premature menopause, and then you can take the ovaries out more towards age 50 when a woman might be going through menopause. And again, the advantage there is avoiding the sequelae of premature menopause, but then you lose the protection against breast cancer. But there are other ways to reduce breast cancer death risk, including prophylactic mastectomy or tamoxifen and so forth. So I think increasingly we may have more options, and really what it comes down to is a discussion with each patient and seeing what their preferences are and coming up with a plan that's best suited to them. The term opportunistic self-injectomy has started to be bandied about. For normal risk individuals, not BRCA1 and 2 mutation carriers, but only about 10 to 20% of the ovarian cancers occur in BRCA1 or 2 mutation carriers. The rest of it, or most of the rest of it, occurs in women who don't have a genetic risk. So if a woman is wanting a tubal ligation for sterilization, why not remove the whole tube instead of just tying the tubes? Or if somebody's having an abdominal operation for gallbladder or colon surgery, why not remove the fallopian tubes? In other words, remove the fallopian tubes anytime you can when women are done having children to reduce their risk of getting fallopian tube cancer. So in British Columbia, they've adapted this very enthusiastically, and over the next decade, it should become clear whether that has an impact on ovarian cancer mortality in British Columbia. And then the idea that genetic testing is becoming less and less expensive as some of the genetic technologies evolve. I've already said that not just based on family history, but now pretty much any woman with high-grade ovarian cancer is having BRCA1 and 2 testing, not only because it'll predict their risk of breast cancer in the future, and not only because other women in their family can be tested if they're found to have a mutation, but also because there's now a new therapy that's been approved by the FDA called olaparib, which is actually a treatment for ovarian cancer in women with BRCA1 and 2 mutations who have the disease. So we're already right now screening all women with ovarian cancer for BRCA1 and 2, not just when there's a strong family history. And as the genetic testing becomes less and less expensive, many of us are convinced that in the future all women will be screened for mutations in BRCA1 and 2, and probably for other cancer genes that, if you carry them, give you a very high risk of cancer. For example, Lynch syndrome, which is responsible for most hereditary colon cancer and some hereditary endometrial cancer. More recently, beyond BRCA1 and 2, a number of other genes have been discovered, like BRIP1 and RAD51D, that also increase ovarian cancer risk considerably. So you can see that here's the lifetime risk of ovarian cancer with BRCA1, about 50% by age 80. For BRCA2, about 15%. Here with BRIP1, it's not much lower than BRCA2. So BRIP1 and RAD51D, it looks like, as best as we can tell, that the lifetime risk of ovarian cancer is about 10%. So Myriad Genetics Laboratories, which has done most of the genetic testing over the past 2 decades, because they initially had patents on testing for BRCA1 and 2, have now expanded beyond BRCA1 and 2 and have a so-called panel test, which they market under the MyRisk name. And I have no conflict of interest. I don't work for Myriad or receive any money from them, but they've been the market leaders. There's a number of other companies like Ambry Genetics and GeneDx that are also doing this type of testing for BRCA1 and 2 and other cancer genes that can dramatically increase cancer risk. So the feeling of those who are advocating for panels like this is that with the way genetic sequencing has gone, it's pretty much not much difference in cost to test for all these genes at once versus just testing for BRCA1 or 2. So there's no real agreement or proof that panel testing should replace testing for just BRCA1 and 2, but it's certainly an evolution. One of the concerns with panel testing is that the more tests you do, the more false positive results you can find. So sometimes genetic testing results can be ambiguous. So if you have a family that you're testing because of concern about hereditary breast and ovarian cancer, and you find a mutation in this, say, CDH1 gene, which is more involved in gastric cancer, and there's no gastric cancer in the family, you're left not really knowing what to do about that. So it can create some problems doing this kind of panel testing. Finally, the Ovarian Cancer Association Consortium, which has gotten a lot of generous funding from OCRF, has identified about 20 other genetic variants that increase risk of ovarian cancer to a much lesser degree. So these genetic variants increase risk of ovarian cancer by about 20 to 50%. But if the lifetime risk of ovarian cancer is only about 1.5% in the population, increasing that by 50%, has a risk of only about 2%. So they're not dramatic changes in risk, but a discovery is still ongoing, and it's conceivable that these sorts of common variants could be used along with other risk factors. So here, recently in our group, we've actually looked at predicting risk of ovarian cancer based on the genetic risk score at the bottom here, using all 20 of these genetic variants, and then combining the 20 variants into a risk score where quintile 1 is the lowest risk, quintile 5 is the highest risk. So if you're in quintile 5, your risk is being increased by about over 2-fold, 2.12-fold, compared to those at the lowest risk. And then when you combine those genetic risk factors with behavioral risk factors like oral contraceptive use, parity, which is whether or not you've had children, tubal ligation, these three factors all dramatically reduce risk of ovarian cancer. So you can see if you've used oral contraceptive pills for 5 years or more, your risk of ovarian cancer is only 0.4, or reduced by about 60%. Similarly, if you have 2 or more children, your risk is reduced by about 50%. Tubal ligation is reducing risk by about 25%. Endometriosis and family history of disease both increase risk. So Lee Pierce, who's also on the Scientific Advisory Board for OCRF, was the principal investigator of this study from our consortium. And then this slide just shows that basically every individual is going to have a different combination of risk factors. So each of these bars represents the percentage of the population that has a given combination of risk factors, and then here's the lifetime risk with that combination of risk factors. So there are certain individuals that just based on the reproductive risk factors and the common genetic variants have up to a 5, 6, or 7% lifetime risk of ovarian cancer. And for some women, that might be enough to trigger wanting to have prophylactic surgery or maybe to use birth control pills as an ovarian cancer prevention strategy. So this just, again, shows how profound a protective effect oral contraceptive pills have against ovarian cancer. For starters, oral contraceptive pills are the safest and most effective contraceptive that we have. They're not 100% safe. There are potential side effects and downsides, but they're used by a large fraction of the population for contraception without much of an appreciation that they reduce risk of a number of other conditions like endometriosis and ovarian cancer. So you can see here that pretty much the longer you're on oral contraceptives, up to 15 or 20 years, the more you decrease your risk of ovarian cancer. So if we don't have a good screening test for ovarian cancer, then this becomes potentially very powerful data for what I would call active management of ovulation, because it's thought that the way the pill reduces ovarian cancer risk is by reducing ovulation. So every month when a woman ovulates, there's basically an explosion on the surface of her ovary, and the fallopian tube fimbria, the ends of the fallopian tubes, are sitting right there. So it's thought that a lot of the genetic damage occurs due to inflammation around the ovary and the tube at the time of ovulation. And so if you're on the pill and shut off ovulation, then that protects against ovarian cancer. And in that spirit, breast cancer, or rather ovarian cancer, is also reduced by breastfeeding, which also prevents women from ovulating for 9 months to a year or more after having a baby. So this is my final slide, and is in a way a synopsis and summary of where we are and hopefully where we're heading in early detection and prevention of ovarian cancer. It's not a one-size-fits-all sort of strategy. I think that for women at the highest risk who have BRCA1 and 2 mutations, BSO is bilateral salpingo-oophorectomy, which is the prophylactic surgery. We've been doing that now for close to 25 years, and I personally have done over 200 prophylactic surgeries, and so I feel like I've probably saved 50 or 100 women from getting ovarian cancer, most of whom may have died from that cancer. So that to me is progress right there in a big way. We'd like to identify a moderate risk group based on either the SNPs, which are the common genetic risk factors, or the reproductive risk factors like pregnancy and oral contraceptive pill use and endometriosis, where we might be able to define a moderate risk population in the range of 5% risk. It may be that ovarian cancer screening performs better in that population because of the higher risk of ovarian cancer. It may be that some of those women might want to select for prophylactic surgery when they're done having children. And then finally, for women who are at average risk, again, we'll find out in December whether the UK study suggests any benefit for ovarian cancer screening with CA-125 and ultrasound. But also, I think we should probably do a better job of making women more aware of the preventive effect of oral contraceptives against ovarian cancer, which is quite profound. So I appreciate the opportunity to share this information with you, and I'm looking forward to addressing some of the questions and comments that you have. Thank you.
Great. Thank you so much, Dr. Burchuk. So we do have some time, about just a few minutes, for questions. So as a reminder, you can type them into the Q&A box that's on the left hand, or the right hand rather, side of your screen. So, I mean, you covered this content, Andy, but I think it might be useful for people to hear you just sort of say it all at once. For a woman whose mother died of ovarian cancer and she's concerned about her risk, what do you think, for a woman in that situation, what would her sort of first steps be, would you recommend? She should go to her doctor and ask what?
Well, I think go to your doctor and talk about it and raise the issue. Depending on whether it's an OBGYN or an internist or a family practitioner and what setting they're practicing in, you might get somewhat different answers. But I think that the bottom line is that now that we understand the genetic component to this disease, it's very important to take a very detailed family history, not just my mother died of ovarian cancer, but how old was she? Can we get the pathology report? Can we see what type of ovarian cancer it was? What other types of cancer, if any, are in the family? And then I didn't mention this, probably because of time, but a really critical element of evaluating for genetic risk of ovarian cancer is referral to a cancer genetic counselor. And those folks are at a real premium. There aren't enough of them to go around. Certainly in major academic centers like Duke and Sloan Kettering and Harvard and the big name places, there are very well developed programs where you have multiple genetic counselors seeing and counseling, and the discussions that lead up to genetic testing take quite a long time and generally are beyond what a practitioner can do, even someone like me who's very knowledgeable and so-called thought leader. When I have a concern, I get my patients to a genetic counselor and make sure that you go through the history, you talk about genetic testing, the costs, the ups, the downs, and then make a decision. And then after the results become available, to meet again with the genetic counselor, discuss what they mean and what sort of interventions would be most appropriate, what the options are, which, is a conversation that can be continued then with a physician, again, ideally with an OBGYN or better yet, a gynecologic oncologist or a medical oncologist who's interested in breast cancer if it's a breast cancer concern.
Great, thank you, Andy. For a patient, there's a patient here who had her mother pass away from ovarian cancer, and she says that she's had a hysterectomy, but she still has her ovaries. And do you think she should have those removed potentially?
Well, again, I think it really all comes down to whether there's an increased genetic risk. Most ovarian cancer doesn't have a high genetic risk, so the cases that are due to a high genetic risk are only about 20%. So, ideally, you do genetic testing on the mom who had ovarian cancer. Now, sometimes if the mother's deceased and it was a long time ago and you can't get access to any tissue from the surgery that the mom had, you may have to start by doing the genetic testing, in the concerned individual who doesn't have cancer yet. That's less ideal because if the mutation's in a family, on average, half the people are going to get the mutation and half are not. So if you do genetic testing on someone and find that they don't have a mutation, it's helpful for them in finding that they don't have the mutation and are not at increased risk for cancer and don't need the prophylactic surgery, but it's not really helpful for other members of the family because the mom might have had a mutation and that person, the daughter, might just have been lucky and not gotten it. So we do prefer to test so-called affected individuals in families who've had cancer, but when that's not possible, testing other family members is the best alternative.
Mm-hmm. So we have a question here along these lines. If a woman has ovarian cancer and she's been tested and has been found negative, what would you advise for her children? Would step one to be get tested, but even if they were negative, they might consider prophylactic surgery as well?
Well, we don't do prophylactic surgery very much anymore in women who are negative for these mutations, unless there's just an incredibly dramatic family history and nothing's been found. If the mom is negative, her children would not inherit a mutation from her, but this can come down from either side of the family, so you really have to look at both sides of the family. When you've got someone who's a mutation carrier and you test their children, you feel pretty good if they don't have the mutation because the average risk of it coming down the other side of the family is, again, very, very low, 1 in 400 or under 1%. But you do have to be aware that it can come down from either side of the family. So, again, this just makes my point of how important it is for genetic counselors to be involved in looking at the whole family. And often this becomes the family as your patient, not just one person as your patient. And having the genetic counselor as part of that team is vital.
Okay, thank you. Can you talk a little bit more about the practice of just removing the fallopian tubes in an attempt to reduce the risk of cancer, or perhaps in a younger person who's doesn't want to lose their ovaries?
Well, I think some people would consider it experimental in the sense that there haven't been big studies done. but just from talking to other experts, I'm getting the sense that it's something that people would consider at this point. I've personally never done that. All the patients I've done prophylactic surgery on have had both the tubes and ovaries removed, but if there was a woman who was highly educated and you had a long discussion and she understood the pros and cons of taking everything out versus taking the tubes out now and then the ovaries later, if she really understood the arguments on both sides and the data that we have and the data that we don't have and wanted to do that, I guess I would be comfortable doing that at this point. But I think that, again, it's still considered a bit edgy and not supported by the same kind of data. In other words, there's no studies of 100 women who just had their tubes out and left their ovaries in and what their cancer incidence and risk was compared to women who had the complete surgery. So it's, like I said, it's a bit on the edge right now, but from what I hear, I think there's some who are talking about it and maybe doing it, but it's in general, I think, only for the minority of folks at this point.
Okay, great. Kathleen Gavin, who is runs the Minnesota Ovarian Cancer Alliance, is sending me a message here saying there will be a trial of salpingectomy with delayed oophorectomy as part of the Ovarian Cancer Dream Team. So there we go. Thank you, Kathleen.
I'm glad to hear that. It'll take, you know.
A small pilot has been done at MD Anderson. So Kathleen, thank you. Let me see, other questions. Let's see, there's a question here about agents like olaparib and their effectiveness for folks with BRCA mutations. Is there any information about what might render something like olaparib ineffective in someone who does have a mutation? I guess this person asking the question, perhaps that's her situation.
The answer is yes, we don't completely understand it, but for example, some ovarian cancers with BRCA1 or 2 mutations, when you treat them with olaparib, you can actually get, because there's billions of cells in a tumor, all it takes is one cell that gets a second mutation that corrects the first mutation, and then that cancer cell forms the basis for a resistant clone that can then grow despite the olaparib treatment. So that's one mechanism. It's called back mutation. So it's like a double negative is a positive all of a sudden and cancels out the mutation that was originally there in the tumor. That isn't the case in all women whose cancers stop responding to olaparib, but it's one mechanism, and there are probably other molecular mechanisms that will be described in the coming years as we use this drug more. But it's certainly welcome that the FDA approved olaparib earlier this year as a therapy for BRCA1 and 2 mutant ovarian cancers.
Great, thank you. I think we will probably end here. Well, actually, before we do, somebody had asked what kind of resources are available on this topic. So Ovarian Cancer Research Fund, which is at www.ocrf.org, we have pretty robust information about ovarian cancer on our website under the About Ovarian Cancer tab. And we actually have a good section there all about ovarian cancer risk, which we largely borrowed with permission from a group called Project Hope, which is very much focused around educating on these issues. So there's a lot of really useful information there. All right, so I want to thank Dr. Burchuk for his presentation, and I want to thank everybody for calling in today. Please take a minute to fill out the survey that will appear on your screen at the end of the event. Your feedback is always really helpful to us as we put together future webinars. And for more information about OCRF, again, you can visit our website at www.ocrf.org. So thanks again, Dr. Burchuk, and thank you, everyone. Have a good evening.
Bye.
Bye, thanks.